Thank you very much, Professor OBESE, an excellent talk. Our next talk is Emad Zakharey from USA, who will be talking about total percutaneous EVAR online.
Good afternoon. Thank you for the privilege of presenting no disclosures, percutaneous EVAR. The number of EVAR procedures has been increasing in the last 10 years. The standard access for an EVAR is bilateral surgical cut down. Although this is a minor surgical procedure, but it has an inherent morbidity of seromas, infection, and delayed wound healing and nerve injury. It also violates the groins. The induced scar tissue can hamper future access to the groin. By lifting the EVAR to a percutaneous level, we can further reduce the degree of invasiveness of AAA. The good side, of course, is that we can make it even with local anesthesia, can be ambulatory. Unfortunately, it can also allow it to be done in the cath lab and other specialists to get involved in it. This is a multi-center randomized trial compared surgical cut down with EVAR, with PEVAR, with ProGlide and ProStar. The readmission rate has significantly decreased with PEVAR compared to open repair. In the morbidly obese, although percutaneous EVAR is more challenging, yet it is in these patients in particular that there is more significant value of doing PEVARs. The findings of trials showed that there is moderate quality evidence of shorter operative time, but there is no difference in bleeding complications. Conversion to open access site is around 10 to 12%. However, this is relatively old data and is probably much less than that. Significant predictors were severely calcified arteries, female gender, age. There is a definite learning curve and it's steep at the beginning. It requires around 15 cases to achieve an 80% success rate in EVAR. Patient selection is the key to success like anything else we do. So avoid calcification of the anterior wall of the femoral artery, calcified stenotic iliac arteries with stents, previous groin vascular surgery. Challenging, but can be done in morbidly obese, complex procedures that involve multiple sheath exchanges, hemodynamically unstable patients as in rupture aneurysm, and patients with iliac stents. The procedure is basically a pre-closure. So it's before putting the big sheath. It's that's just before I forget to mention that. So you prepare everything you have, and these are the equipment needed, and then access under ultrasound guidance, access site angiogram, to deploy two commonly used ProGlide, two ProGlides at different angles, and tag sutures. Access angiogram is a key. Access ideally should be on the low side, so avoid having a bleeding with a retroperitoneal hematoma, and you rewire the first ProGlide, and deploy the second one. Before completion, after you're done with the procedure, you remove the big sheath, and after completion of the procedure, you remove the big sheath and you tighten the wires. When you remove this sheath, take an external iliac arteriogram to make sure there is no issue with the external iliac and the patient is hemodynamically stable before you proceed. There are device-specific complications, which is technical failure, or vessel-related complication like bleeding, iliac artery dissection, pseudoaneurysm, or thrombosis. In conclusion, percutaneous EVAR using the ProGlide is effective. There is moderate quality evidence of shorter operative time. There is a steep learning curve. It allows secondary intervention easier in the groin that is not violated. Has lower admission rate, shorter operative time, preserves the unscarred the groin. A totally percutaneous approach can be achieved in 80% of EVARs with technical success of 97%. Cost and reimbursement is an issue. On average, it's $5,000 for 4 ProGlides to do both groins. To stay ahead of the curve, if you're starting this technique, you need to use the ProGlide in regular interventions. You can use it in the contralateral groin and avoid the challenging cases. Thank you.
Thank you very much for that very clear presentation. The next speaker is Professor Tommaso Donati from Gemelli in Rome. He's a very good friend of mine who will be talking about